course for St. Joseph's College in Maine Family Nurse Practitioner Program. This is advanced assessment. I'm actually doing an assessment on the patient now. We do a head to toe. This is for the Unit 2 assignment submission. First things first, I'm going to start by letting the patient know I'm going to be doing a physical examination on you from head to toe. Just follow my instructions. I'm going to be asking you to lie down at a point, stand up. We're going to be doing several things. It's going to take a little while because I'm going to be pretty comprehensive. I'm going to cover the top of your head to the bottom of your feet. I'm going to cover all major systems and organs of your body. So I'm going to let the patient know that. And then I'm going to start the assessment. So the first thing I want to do is I want to actually inspect the head and the hair. I want to look at the hair for any evidence of any nits or infestations, alopecia, stuff like that. I want to examine it. I'm going to check for symmetry in the face. I want to make sure that the patient's face is symmetrical and whatnot. So the second thing I'm going to do after I've inspected the hair, the symmetry of the hair, and the symmetry of the face, I'm also going to palpate. I'm going to feel the scalp for any kind of deformities. I'm going to ask the patient, do you feel any tenderness or pain when I press down?
No.
Okay. Do you feel any tenderness or pain when I press down back here?
No.
Okay. Then I'm going to check the temporal artery for tenderness. I feel the temporal pulse start right here. Do you feel any tenderness when I press down?
No.
Okay, and then I'm going to check the lymph node with the preauricular in front of the ears. I'm going to feel for tenderness or swelling of the lymph node. Then I'm going to check the back of the head, the occipital. Then I'm going to check the tonsillar, which is right at the edge of the jaw here. And then I'm going to check the submandibular, the submental, the anterior cervical, posterior cervical, and the supraclavicular, which I don't really feel any swelling or anything like that. Okay, the next thing I'm going to do is I'm going to inspect and do assessments in the various areas of the face and head. So we have the ears, eyes, nose, mouth, throat, neck. So I'm going to perform several tests. First, I'm going to check the patient's ears first, to see if the patient has any swelling, redness, deformities, lesions. One thing that's important when I'm checking the entire body is that I make sure to check for color, texture, moisture, turgor, temperature, edema, lesions, bruising, nevi, and scarring. I'm going to check the entire body. Of course, I've already I should have gathered a thorough history by now, so if the patient's had any prior surgeries or trauma or accidents, I could have gathered that by now. So where I was at the ears, I'm going to inspect the ears for any kind of deformities, redness, swelling, any tenderness or pain.
No.
At your ears? Okay. Then what I can do next is I can either do an otoscopic exam, which I don't have the equipment for that, but I'm going to pretend. I'm going to lift the ear up like this, look inside the ear. I want to make sure that the eardrum is pearly gray and that there's a cone of light appropriately in there. We do the same thing on this side. I can also test for hearing, so I have several methods to test for hearing. I can do the whisper test. I'm going to whisper a word, and I have the patient repeat it to me. And of course, it's going to be out of the patient's view, so she can't read my lips.
Baseball.
Okay, do the same thing on this side.
Baseball.
Okay. Then I can do the Weber and Rye test. Now the Weber test, I'm going to vibrate. I've got a tuning fork. So I'm going to vibrate the tuning fork. I'm going to place it on top of the patient's head. Now can you feel the vibration of the tuning fork?
Yes.
Okay. Does it feel uneven on either side or even?
Even.
Okay. And then I'm going to do the Rhine test. So I'm going to test air conduction versus bone conduction. I'm going to vibrate the tuning fork. I'm going to place it on the sphenoid process behind the patient's ear. It's actually, the mastoid process behind the patient's ear, and I'm going to see if she hears it. Do you hear that?
Yes.
Okay. And then I'm going to do air conduction. Do you hear that?
Yes.
Okay. Do the same thing on this side. Do you hear that?
Yes.
Do you hear that?
Yes.
Now, which one was louder? Now, the patient should say that air conduction was louder, and that would indicate normal hearing.
The second one was louder.
So when I put the fork in the air?
Yes.
Okay. So the next thing I'm going to do is I'm going to check the eye. So I want to do several things here during the eye exam. I'm going to check for visual acuity, both gross and peripheral visual acuity. I'm going to check for the six cardinal gazes. I'm going to check for light reflex, accommodation, and light reflex should be both direct and it should be on both sides. So what I'm going to do is I'm going to first start off with the light reflex. So I'm going to flash a pen light in the patient's eyes. Now it would help to have the lights dim at this point. I'm not going to do that, but I would dim the lights and see, and I'm going to make sure that the patient's eyes dilate. It should dilate on both sides when I put it in either eye. That's normal. I'm going to do convergence. I'm going to have the patients follow the pen. Follow the pen for me for your eye. Okay, and then I'm going to do accommodation. So could you stare at the pen and then stare ahead of the pen? Okay, stare at the pen. Stare ahead of the pen. Okay, the patient's eye should dilate upon staring off into the distance. Then I'm going to do the seven cardinal gazes. So I'm going to have the patient, I just want you to follow these directions. Stare at the pen. Just follow the pen with your eyes. Okay, so now I've tested the patient's extraocular movements. That's cranial nerves 3, 4, and 6. I've tested hearing, which is cranial nerve 1. Cranial nerve 2 is the optic nerve, which I've tested to see if that's worked out. Her vision seems to be appropriate. The next thing I'm going to do is while I'm looking at the face, I'm going to do cranial nerves 5 and 7. So I'm going to, another thing with the eyes, I've got to make sure to check the sclera. Can you look up for me? And the conjunctiva for any kind of redness. I'm going to inspect the eyebrows, the eyelashes, if you can close your eyes for me, and the palpebrae to see if there's any kind of redness, swelling, deformities, asymmetry. I want to make sure that it all looks in line and that it looks appropriate. There's no indication of infection. So the next thing I'm going to want to do is I'm also going to massage the patient's masseter muscles. If you can punch down for me. And that's actually checking to see if the cranial nerves are working properly because of muscle movement in the face. So I'm going to have the patient frown, smile, raise your eyebrows, and puff your cheeks out. And what that does is that actually tests for cranial nerve 7. Cranial nerve 5 was actually to test for the masseter muscle, which is a muscle of mastication to the jaw. I'm also going to test the different areas of the face with a wisp of cotton for fine touch to see if she has proper sensation. So as I touch a spot, I want you to tell me whether or not you feel it or not.
Yes. 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 Yes.
Okay. So now that I've done that, I'm actually going to I've done the ears and the eyes. I'm going to want to inspect the nose, the throat, and the mouth next. So when I look at the nose, I'm going to want to make sure it's midline. It's straight directly proportional to the face. The nares look appropriate and they're both symmetrical. There's no redness, no discharge or swelling. I do want to make sure that there's no signs of infection or drainage or anything like I mentioned. So at this point, I would take the otoscope and I would inspect the inside of the noses. I would also palpate the sinus cavities to see if she has any tenderness when I press down. Do you have any tenderness? Or?
No.
Okay. Same thing up here. Now, of course, if the patient did come in, with signs of sinus infection, you would want to make sure to do that as well. The next thing I'm going to do is I'm going to have the patient open her mouth, and I'm going to check the inside of her mouth. I'm going to check the buccal mucosa, see if there's any lesions, any kind of discoloration, leukoplasia, thrush. I'm going to check to see if she has any signs of gingivitis or cavities. Do you have any pain or tenderness inside of your mouth?
No.
Any throbbing, anything like that?
No.
Okay. Open wide for me. Okay, and what I can do at this point is I'm actually going to take a piece of gauze and I'm going to displace her tongue so I can look around the inside of her mouth. So of course I have my pen light. Stick your tongue out for me. I take the gauze and I put it on her tongue and I'm going to look on the inside. Open wide for me, please, as wide as you can. Again, look on the inside of the mouth, underneath the tongue for tumors or anything like that. I'm going to check in the back, of course, I'm going to check. Could you open wide for me? Say ah. And of course, I can have a tongue depressor at this point. Ah. I'm going to check for uvula deviation or paralysis, to see if it's going down to one side. Her uvula does not appear deviated. It appears in line. Her tonsils are not enlarged, so I'm not going to grade them. But her mouth looks great. You can close your mouth now. So what I'm going to do next is I'm going to actually inspect the neck and make sure that I go through and check the skin of the neck. Again, color, temperature, moisture, turgor, edema. I've got tangential lighting if I suspect a little swelling of the thyroid. So when it comes to the thyroid, I do want to make sure that I inspect that properly as well. So I have lighting right here. I could turn on, let me put it on camera. As you can see, I have a lamp. So I could look at it, if I suspected that. But I'm going to make sure her trachea is midline. It looks symmetrical. It doesn't look like it's deviated. I'm going to check and see if her thyroid does not look enlarged. It looks appropriate. So what I'm going to do is I'm actually going to get behind the patient. You can lean a little bit over here. And I'm going to inspect her thyroid. So a little bit toward that direction. So I'm going to come from behind the patient, and I'm going to go right near the bottom of the sternocleidomastoid muscle. This I'm going to ask her to swallow. Can you swallow for me, please? Okay, I feel the very edge of the top of the thyroid gland as she's swallowing. So it's appropriate. It's not inappropriately enlarged. So you can sit in the position you were sitting before. Okay. I've inspected her skin for color, any kind of edema, anything like that. So now what I'm going to do, I've already checked the tongue. It's appropriately midline, and those are cranial nerves 9 and 12 of the uvula as well. So cranial nerve 11 would be her spinal accessory muscles, the sternocleidomastoid and the rhombus muscles, the muscles that are in the neck. So I'm going to have her show her shoulders. Can you show your shoulders? Okay, and that shows that she's got appropriate strength and she's got cranial nerve 11 function, spinal accessory nerve. So now what I'm going to do is I'm going to test the range of motion of her neck. I'm going to give her several directions to move her neck. Could you flex your neck forward, your chin toward your chest, and then look up toward the ceiling. Okay, I want you to rotate your neck toward your right shoulder, and then rotate it toward your left. Okay, now I want you to face your head forward. I want you to move your head to the side, your ear to your shoulder. There you go. And do the same thing on the other side. Now once I've inspected the neck, what I want to do is I want to begin to inspect the posterior chest. So I'm going to have the patient lean a little bit toward this way. If you could lean a little bit toward the edge of the bed. I'm going to move your hair out of the way for a minute. Now she is wearing a sports bra. I'm going to have to move your bra in several directions so I can listen properly and inspect.
Okay.
Okay, so I want to make sure I let the patient know that before I do anything that way. I don't do anything inappropriate. If she thinks it's inappropriate, I cannot do it. But I'm going to inspect her posterior chest. I'm going to check the skin again, color, temperature, lesions, moisture, turgor, any sign of edema, bruising, scars. I'm gonna just check it out and make sure I don't see anything that I feel is inappropriate. Okay, her chest looks good, so I'm not going to mark any abnormalities for that. Next thing I want to do with the posterior chest is I want to palpate for chest expansion to make sure that her chest is properly expanded. I'm just going to lean over for just slightly. I'm going to place my thumbs on the bottom of her rib cage, and I'm going to sort of form a slight pouch on the spine with my thumbs. Take a deep breath for me. And I'm going to watch for chest expansion as it goes up and down. Okay, it seems even, so I'm going to have you lean. You can just stay in the same position. Next thing I'm going to do is I'm going to palpate for tactile fremitus, and I do this over four main quadrants. So if you could say 99 for me.
99,
Okay.
99, 99, 99, 99, 99, 99, 99.
As you can see, I've done this over 4 main areas of each lung. The next thing I'm going to do is I'm going to actually percuss the lungs. I'm going to percuss it in several spots. So I'm going to have to go in the intercostal spaces. I'm going to start with the second intercostal space from the top to the midline of the scapula of the left lung. So I want to take my middle finger and then tap with my other middle finger on the distal part of my finger, of the last joint area, and I want to make sure that there's appropriate sounds. So I'm going to go between each one on either side, and I'm going to tap it. Maybe you can't see that very well from this angle, so I'm going to turn a little more so you can see it. Okay, now that I've percussed and it sounds normal, what I'm going to do is, after I've percussed, I'm going to auscultate in the same spots. You can stay in the same position. I'm going to auscultate in the same spots, and I'm going to start above the scapula and the apex of the lung, and I'm going to work my way down, going down either side of the lungs. So I'm going to listen for proper breath sounds, make sure there's no crackles, wheezing, or lung time. Take a breath in. Okay. Okay, now that I've listened for breath sounds, I'm going to listen for egophony, bronchophony, and whisper pictoriloquy. Now, what I'm going to have the patient do, I'm going to auscultate with this portion. With the egophony, I'm going to have the patient say E over each of the auscultation points. With the bronchoscopy, I have the patient say 99 over each one of the auscultation points. And the whisper pictoriloquy, I'm going to have the patient whisper 1, 2, 3. Now this is, of course, to check to see if there's any changes in the sound. If there's any changes, it could indicate consolidation or changes in the lung space that is abnormal. So what I'm going to do is I'm going to start the process. Okay, I'm going to have you say, each time I move the stethoscope, I want you to say the letter E.
E. E. E. E. E. E. E. E. E. E. E.
Okay, now I'm going to do that one more time, except I want you to say the word 99. Okay?
Okay. 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
Okay, I'm going to do that one more time, except I want you to whisper the numbers 1, 2, 3. Okay? Okay. Now that I've examined the posterior chest, I'm going to move on to the anterior chest. So I'm going to have the patient turn around. Turn around and sit forward. Like that. I'm going to put your hair back here. Okay. Now what I'm going to do is I'm going to do the same thing at the front. I'm going to inspect the anterior chest for color, temperature, moisture, turgor, temperature changes, any asymmetry. I'm going to inspect the anterior and posterior chest as well to see if she has any barrel chesting or concaveness. I'm going to also watch her breathing as well as part of the chest examination to see if she's having any difficulty breathing, use of the accessory muscles and whatnot. So I've inspected the chest, I've looked at the skin, it looks appropriate. She is wearing a bra, and as a patient, she may not feel comfortable with the male provider. I can just simply ask her, have you had any breast tenderness or swelling?
No.
Okay, have you noticed any changes in your skin color or bruising or any kind of moles or rashes or anything like that in your breast area?
No.
Okay, I can ask the patient that if she doesn't feel comfortable with me examining it. If I did have suspicion, I would insist to examine it, or I could get a female provider if she didn't feel comfortable. Okay, at this point, I'm going to actually listen to your breath sounds in the front. So I just need you to take a deep breath every time I go through. Okay? But first, I'm actually going to do something called tactile affirmatives, which I did on the back. I'm going to listen to the vibrations of your lungs. So I'm going to do that in the front. I'm going to palpate, for tactile affirmatives, which is similar to what I did in the back. If you could say the word 99.
99. 99. 99. 99. 99. 99.
If you could do me a favor and lift your right breast up to the midline, so I can listen.
99.
Okay. Do the same thing on this side.
99.
Okay, now I've listened to the tactile affirmatives. I'm going to actually listen. I'm going to auscultate for the lung sounds. And I'm going to do this the same way I did in the back. I'm going to use the diaphragm stethoscope. I've actually got a cardiac stethoscope, a cardiac master stethoscope. So by pressing harder, the diaphragm actually becomes a bell. So that comes in handy when I do have to listen to the heart sounds and for breathes and whatnot. Also, what I did forget to do is I forgot to check the carotid pulse, but since she's sitting up, I can check that right now. She's got a palpable carotid pulse. I can also auscultate for bruise of the carotid. Which she doesn't seem to have any, so I forgot to do that as part of the neck examination, but there is an order to it, but I can go back and still do it if I did forget. So I'm going to auscultate for the lung sounds in the anterior chest. Take a breath on. You can take your right breast, move it toward the midline for me. I want to make sure on the right side that I do catch the right middle lobe, as it sometimes can be difficult to get to that, especially with women. So if you could move your breast in the midline. Okay, same thing on this side. Okay. The next thing I'm going to want to do is I'm going to want to check the heart. And while listening to heart sounds, I'm actually going to want to put one hand on the carotid artery. And this helps because I can match the beat of the heart with the pulsations through the actual artery itself, carotid. I'm going to start right here. This is actually the aortic side. And then the pulmonic side. Third point. Which, starting from the beginning, I'm actually going to the right second intercostal space-donor border, the left second intercostal space-donor border, and then I'm going to the third intercostal space-donor border, which is Earth's point, and then the fourth intercostal space, which is the tricuspid area, and then the fifth is actually going to be the also the tricuspid area, the fifth intercostal space. If you could do me a favor and lift your breast up for me. And then I'm going to listen at the mitral area, which is the about midline, mid-clavicular line. This is also where I'm able to, since this is considered the apex of the heart, I'm able to palpate the PMI at this area. So I'm actually going to do that for 1 minute. And I do have the PMI right now. So I'm going to check that for 1 minute. Okay, so now that I've done that, the next thing I'm actually going to have the patient do, I'm going to have the patient lie down. I've palpated the PMI, so I'm going to have the patient lie down at this point, and this is actually a good chance for me to check the patient's heart sounds again, but first I'm going to palpate for thrills over the heart sound points. So I'm checking the aortic area, the pulmonic area, Erb's point, tricuspid area. And could you lift your breast up for me? And then I'm going to check the mitral area. And I don't feel any thrills. So while the patient's lying down, I'm also going to auscultate heart sounds again in the same areas. Okay. Well, now that I have auscultated for the heart sounds, and I've done that, I'm actually going to check the JVD at this point. I've got her sort of leaned up. I don't have the ability to raise the head of the bed up to a 30 or 45 degree angle, so I've sort of simulated it. But what I'm going to do is I'm going to have the patient look straight forward, and I'm going to measure, I'm going to estimate her jugular venous pressure by measurement of the pulsations of the jugular vein in the neck. So what I'm going to do is I'm going to take, I've got a ruler here. I'm going to take this ruler. I've got a straight line. I'm going to measure where I see the pulsations from the sternal angle here at the sternum. So I see the pulsations right. I do see them. They're right here at the tip of like right above her clavicle. So I'm going to see where that's measured, and I'm going to see where that's estimated here on the ruler. So she has approximately 1 centimeter of jugular venous pulse. So again, that is an estimation of a jugular venous pressure. So the next thing I'm going to do now that I have the patient lying on her back is I'm going to move down to the abdomen. Now I've inspected the chest, the heart, the lungs. So now I'm going to go down to the abdomen. I'm going to inspect it, again, color, moisture, temperature, edema. Edema is especially important for ascites. I'm going to check for turgor. I've got temperature, her abdomen feels appropriately warm. Color is appropriate. The next thing I'm going to do is I'm going to listen for bruits over her main arteries in her abdomen. Now, her abdominal aorta, which is about mid-epigastrum, the renal arteries to the left and right, the iliac arteries, which are actually a little bit below the umbilicus, and then the femoral, which is between the iliac crest and the pubis symphysis on either side, and it's right below the inguinal ligament. So it goes NAV on either side, coming from lateral to medial. So I have nerve, artery, vein on either side of the femoral artery. So I'm going to feel that. I'm going to listen for bruits and make sure that that's all appropriate. Okay, I'm going to have you lower your pant line a little so I can actually look. I've got to listen to some arteries. So just lower the pant line slightly. Okay. Okay, same thing on this side. Okay, the next thing I'm going to do, I'm going to auscultate the 4 quadrants of her bowel. I'm going to listen for appropriate vowel sounds. Then I'm actually going to percuss for tympany, dullness, to see if there's any inappropriate dullness or flatness in areas that should be more tympanic the bottom. Okay, now I'm going to palpate. Now at this point I can also palpate both the liver and the spleen. Now the liver I should be able to palpate just below the right costal angle, and the spleen should not be palpable. The spleen would be palpable, could be palpable in a person who has splenomegaly due to trauma or other reasons. So what I'm going to do is I'm actually going to palpate the liver. I'm going to take my left hand and put it right below the costal-vertebral angle, and I'm going to have the patient take a deep breath right below the costal-vertebral angle. Now, I'm going to take my right hand and put it below the costal-vertebral angle. So you take a deep breath for me. Okay, I should be able to feel the edge of the liver right here, which is actually I can. So on the other side, I'm actually, for the spleen, I'm going to put my hand around the 11th and 12th rib, similar to what I did on on the liver side, except using opposite hands. I'm also going to have the patient take a deep breath, and I'm going to see if I can feel the spleen. It should be right underneath the costovertebral angle. So take a deep breath for me. All right, I can't feel the spleen, but that's normal. What happens is when the patient takes a deep breath, the diaphragm actually pushes the abdominal organs lower, so it pushes the liver and the spleen lower, so I can feel it better. Thank you.
Yeah.
Okay. Now the next thing I'm going to do is I'm going to have the patient continue to lie down. Now, what I can do at this point is I can test for range of motion of her lower extremities. I'm going to test for her toes, her ankles, and her hips while she's lying down. So first things first, I'm actually going to look at her feet here. So I have my reflex hammer here. So what I'm going to do is I'm going to fan her from the bottom of the heel. And I'm going to go up, and she should not fan her toes out. I got the bottom of her heel. Bottom of her heel, her big toe. She should flex her toes. If she fans her toes, that's a bad thing, because if she fans her toes out, it's actually a reflex that should have diminished in childhood. So I'm going to look at her feet, between her toes, to see if she's got any dryness, cracking, anything like that. Again, I'm going to inspect for color, moisture, temperature, edema, nevi, lesions, scarring, bruising. I'm going to look for any abnormalities, any wounds, any cracking skin, dry skin, edema, swelling of her toes. So I'm going to feel the joints of each one of her toes, like so. And then I'm going to test for range of motion and muscle movement. So if you could kind of crunch your toes in for me, and bring them up, fan them out. Okay, so what I'm doing now is I'm testing for abduction, adduction of the toes. I'm testing for flexion and extension for range of motion of the toes. And then I'm going to work my way up the foot. I'm going to check capillary refill of the toes also, which I'm going to make sure it's less than 3 seconds. I'm going to check for pulses. I'm going to check the dorsalis pedis, which is right to the medial to the, it's right lateral to the extensor of the great toe. Or you can work your way laterally if you don't feel it, which I do feel it. I'm going to check the dorsalis pedis pulse, which is appropriate. I'm going to work my way toward the ankle joint now. She's got, if you could tell me you feel any tenderness or pain.
Okay. No, I don't.
Okay, go on this side. Okay. So I felt the malleolus, both the medial and the lateral, on both ankles. And then I'm going to have the patient actually do some range of motion exercises and test her strength of her ankle joints. So if you could take your the top of your foot and move it toward your head. Okay, now move it down. Okay, if you could take the inside of your foot and move it toward the inside of your body. Very good. And now outside. Okay, very good. Now what I did was eversion, dorsal flexion, plantar flexion, and inversion. So I did all those. Now I'm going to test for strength. I'm going to test for plantar and dorsal strength. So if you could push down on my hands like a gas pedal, very good. I'm going to lift up. Okay. Now I've inspected the ankles. Now I'm going to work my way up the leg. I'm going to skip the knees, because the knees I can actually check more appropriately while the range of motion while she's sitting up again over the edge of the bed. But what I'm going to do is I'm going to inspect the knees. I'm going to make sure that there's symmetry again, that there's color, moisture, temperature, edema, any lesions, scarring, anything like that. I'm going to inspect it properly. I'm going to feel the condyles on both sides. I'm going to feel the patella head to make sure it's appropriate. Could you feel any tenderness or pain?
No.
Okay. I'm going to do the same thing on both sides. See if there's any tenderness or pain. We'll feel the condyles. Okay, feels appropriate. And the next thing I'm going to do, I work my way past the knees. I'm going to go up to the hips now and test a little bit for range of motion in the hips. So I'm going to feel the major areas of the hip and bone. Do you feel any tenderness or pain? I'm going to inspect also the hip joint for any tenderness or pain, point. I've got her greater trochanter and her iliac crest. But then I'm gonna test for range of motion of the hip muscles. So I'm gonna have the patient flex their hip, extend their hip, abduct and adduct the hip, and as well as do internal and external rotation to check for strength. So if you could do me a favor and lift your leg up at the hip joint. Okay, same thing on this side. Okay, very good. If you could move both of your legs outward. Okay, and then inward. Okay. Do me a favor and lift and put your knee to your chest. Okay. And then what I can do, the patient has done this extension. What I'm going to do is I'm actually going to check her internal and external rotation. So I'm going to have the patient, I'm going to move her joint inward, and that's actually going to test for external rotation. And then I'm going to move the joint outward, and that's actually going to test for internal rotation. So if you could do that on your own right now, you can move it inward, move it outward. Okay, very good. And then I'm going to do the same thing with the left leg. If you could move it inward, and then move it outward. Okay, do you have any pain or any kind of tenderness when you do that at all?
No.
Okay, good. I've checked the range of motion of the hips. I've inspected them. I've palpated the greater bony prominences for tenderness. I've palpated the knees and I've palpated the feet. So what I'm going to have the patient do at this point is I'm going to have her sit up for me. You can sit up for me, please. Now, the next thing I'm going to do is I'm going to work on the upper extremities. So I'm actually going to work on the upper extremities to test for, I'm going to start with the fingers, go up the hand to the shoulders, of course elbows and shoulders. I'm going to make sure that she has range of motion, capillary refill, and I'm going to test the radial pulse. So let me see your hands. You're going to check. I'm checking your hands here. You're going to look for symmetry of the hands. Again, color, temperature, moisture. I'm going to check the joints and make sure there's no discoloration. If the patient has told you about any complaints in the history at this point, you would want to inspect further. So I'm going to check the finger joints. I'm going to hold each joint between my first finger and my thumb to see if I feel any abnormalities, any deformities, or nodules, which could indicate arthritis, typically in older patients. You can also look for ulnar drift for rheumatoid arthritis. So I'm going to check the thumb joint as well. So if you could clench and make a fist for me, extend your hands out, fan your fingers out, bring them back in. Okay, very good. So now I've tested for abduction, adduction of the fingers, and flexion and extension of the fingers. Now I'm going to test for thumb strength. So if I could have you move your thumb outward. Move your thumb outward. Your thumb. Okay? Inward. Okay, same thing on this hand. Okay, inward. Okay, so I've tested for her thumb strength against resistance. The next thing I want to do, if you could hold your hands up for me, please. I'm going to want to have her squeeze my hands to test for strength. Squeeze as hard as you can. There you go. Good. Then the next thing I'm going to do is I'm going to have I'm going to work my way down the upper extremities and check out the wrist. So I'm checking out the wrist. I'm going to check the ulnar and the radial prominence of the wrist, of the wrist muscles. I've already sort of inspected the hand and checked out the metacarpals. What about the ulnar and radial prominence? I can feel that. I can also check for the radial pulse at this point, which is good. And if I haven't checked for capillary refill, I can do that as well. Should be, again, less than 3 seconds on either side. We do the same thing on this side. I'm going to do you feel any pain or tenderness when I do that? So I've inspected it. I can check for the radial pulse. I'm going to do the same. I can also check for the ulnar pulse. I could do the Allen test now if I suspected any kind of blockage in the arteries. Okay, now I'm going to test for range of motion of the wrist joint. So I'm going to have you hold your hand out like that. If you can move your fingers toward the ground, now upward. Okay, if you can put them back to where they were. If you can kind of move your hands laterally, like that, and then toward the inside. Okay, what I've done is I've tested for ulnar drift, radial drift, a flexion, extension, if you can move your joint in a circle like that. Okay, now I've tested for a rotation. So the next thing I'm going to do is I'm actually going to check out the elbows. So I'm going to have the patient hold her elbow at about a 70-degree angle. I've got it right here. I'm going to inspect it again, color, moisture, temperature. It feels perfectly warm. She doesn't have any unusual redness or warmth, any pain or tenderness. So we'll feel the lateral and the medial epicondyle. I'm also going to feel the olecranon process of the ulnar bone to see if she has any tenderness or anything like that. I'm going to have the patient both bend her elbow and extend her elbow, her arm, against resistance and on her own. So if you can bend your elbow for me, extend your elbow. Okay, bend it, extend it. Okay, and now do the same thing on this side. I'm going to have to check the epicondyles for any tenderness or pain.
No.
Okay, the olecranon. If you can bend your elbow, extend it. Okay, do it again. All right, do it again. I'm going to have you hold on the ball. Okay, do it again. Okay, good. Well, now I've inspected the elbows. I'm working my way up to the shoulders. I'm going to check the bicep muscle, the head of the bicep, if I can see any pain or tenderness. Can I touch here?
No.
What about here?
No.
Okay, I'm going to inspect the shoulders and the shoulder joints. Again, color, temperature, moisture, edema, turgor, levi, bruising, scarring, lesions. I don't, her shoulders appear normal upon inspection, so I'm going to palpate the joints of the shoulder. I've got the acromioclavicular joint. I'm going to check the joint where the clavicle meets the sternum right here. Do you have any tenderness or pain when I do that? Okay. I can also check about where the bursa are. That's a common injury on the shoulder. Her rotator, of course, the rotator cuff is where a lot of muscles connect, and it's really a soft joint. It's where a lot of muscle injury and soft tissue injury, joint injuries occur. So I'm going to check. Do you have any tenderness or pain?
No.
Okay. Then I'm going to test the range of motion of the patient. So what I'm going to check for flexion, internal rotation, external rotation, extension, and abduction and adduction. So I'm going to have you, if you could do me a favor and raise your hands above your head. Okay, now take your hands and put them behind your head. There you go, just like that. Now what I've done is I've tested for flexion and for external rotation. So if you could put your hands by your side again, and take and put your arms behind your back. Okay, I've tested for internal rotation now upon doing that. Now, hang your hands on your side, okay? And if you can lift them up like that. Okay, now put them back down on your side. Now I'm going to have you do that again, except I'm going to offer a little resistance, okay? Go ahead. Do the same thing again. Okay, good. So I've tested for abduction and adduction in the shoulder joint. So now that I've had her do that, I'm going to have her make some circles with her arms too. If you can make circles in the air like that, larger circles if you can. Very good. Now that's testing for circumduction, actually. Okay, you can put your arms down. Okay, now I'm going to test light touch of the upper extremities. I'm going to make sure she has sensation in all of her upper extremities. You can hold your arms out for me, please. What I'm going to do is I'm going to touch this cotton ball to different areas of your arms, and you can tell me, just let me know if you feel it.
Okay.
Hold your arms out. Close your eyes.
Yes. 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 Yes.
Do the same thing on the right arm.
Yes. 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 Yes.
Okay, now what I've done is I've tested the sensation ability of the ulnar medial radial nerves of the hand, and of course the brachial nerves as the nerves go up the arm into the brachial plexus of the shoulder. So the next thing I'm going to want to do is assess sterignosis and graphesthesia. So what I'm going to do is I'm going to have the patient grasp a familiar object, close her eyes and grasp a familiar object, and I'm going to have her tell me what it is. Okay? You close your eyes for me, you're going to place an object in your hand, you just tell me what it is.
A pen.
Okay? The next thing I'm going to do is called graphesthesia. That's actually, I'm going to draw a number in the patient's hand, and I'm going to have her tell me what number that is. And of course, what all this is doing is testing for neurological function. So if you could do me a favor, I'm going to draw a number in your hand, and I need you to tell me what it is, okay?
3.
Okay. Next thing I'm going to do is I'm going to actually test for vibratory sensation at the wrist. I have my tuning fork, and this is just to make sure that she has vibratory sensation. So we do it on the ulnar prominence. Can you feel that?
Mm-hmm.
Okay. And about on this side.
Yes.
Okay, good. So the next thing I'm going to do is I'm going to test for cerebellar function. I'm going to have her do a flip-flop. So what I want you to do is I want you to tap your hand on the top of your leg like that, lift it up, turn it over, and then tap the back of your hand. Okay, so keep doing that as many times as you can, as fast as you can. Okay, now do the same thing with your left hand. As fast as you can. Okay, good. Now, the next thing I'm going to do is I'm going to have the patient touch her hand to her nose and into my finger. And this is going to test her ability to, this is also cerebellar function, fine motor detail. So if you could touch your finger to your nose and then touch my finger in the air. Okay? And touch your finger to your nose again. And keep doing that. Okay, good. Now the next thing I'm going to want to do, I've tested appropriately for cerebellar function, but I'm actually going to have the patient do what's called serial finger. If you can hold your hands up and touch your thumb to each one of your fingers, you go back, and then touch your thumb and your finger, your index finger repeatedly. Okay, that's serial function, so she has the ability to do that. And then now I'm going to test for deep tendon reflexes. So I have my hammer here, a trusty hammer. So I'm going to start at the brachioradialis, which is actually about 1 to 2 inches below the radial prominence of the wrist. And what I should see is slight supination and flexion of both arms of the reflex. Okay. Okay, and then I'm going to test for brachial reflex. So put my finger over the biceps tendon. I'm sorry, my finger over the bicep. Then I'm going to check for tricep. You can hold the arm right there. Okay, same thing on this side. The triceps tendon. Okay, very good. Now I'm going to test for patellar, which I go a little bit below the patellar. Okay, SAR reflex. SAR reflex on the left side, and then I can do Achilles. I'm going to hold her foot up. I'm going to adjust the camera so we can see this a little better. But I'm going to hold her foot up slightly dorsiflex and then press it. It should cause her ankle to pop down. You can see that. We'll do the same thing on the left leg. Okay. So I've tested the patient's reflexes. Now I can test for knee flexion at this point. I've got her leaning over the bed. So I'm going to have you lift your left leg up for me. Okay, and down. Okay, up on this side. And down. Okay, very good. Now, at this point, I've already tested the knees. I've tested the hips. I can do light touch of the lower extremities to make sure her nerves and dermatomes are working properly. So I'm going to work my way up. I want you to close your eyes for me. I'm going to touch this cotton ball to the bottom of your feet and up your legs. I want you to tell me if you feel it. Okay?
Okay.
Okay?
Yes. Yes. Yes.
Okay, we'll do the same thing on your left leg. I'm sorry, your right leg.
Yes. 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 Mhm. Yes.
Okay. Now the next thing I'm going to do is I've actually assessed the patient's knees, the lower extremities. I'm going to have the patient stand up so I can assess her spine, and so I'm going to adjust the camera so she can stand up. So if you stand up for me, please. Okay, I'm going to have her stand like this. So I'm going to inspect her spine. Make sure it's got the proper curvature. She does have a slight kyphosis. I'm going to raise the angle of the camera here so you can see it better. You can face a little bit toward that way. She has a slight kyphosis of her spine here, slight more than normal. I should see a normal lordosis in the lower back, which she does have. I'm going to inspect it to make sure she's got shoulder symmetry for asymmetry. And then next I'm going to palpate. Again, I'm going to do color, moisture, temperature. When the field feels appropriately warm or turgor is good. I'm going to check for nevi, bruising. I've already sort of checked the chest, upper chest area when I checked the posterior chest earlier, but now I can look at the lower back for moles or nevi. It's a very common area for moles and nevi. Sorry, nevi is a mole to be. So lesions, scarring. I check her lower back. So what I have a patient do at this point is if you could actually lean forward for me, please. I'm checking for spinal flexion and touch your toes, best you can. I'm checking for spinal flexion, and I'm also looking for symmetry while she bends over. The lordotic area should actually flatten. So I'm going to check for symmetry. I can do that by placing my hands here and seeing if it feels uneven. Okay, and you can come back up again. Next thing I'm going to do is I'm going to have the patient extend her back backwards and place my hand right above her ischial spine in the back, which I can feel right here. I'm going to have you lean back for me. Okay, same thing on this side. And back. Okay, very good. And then I'm going to check for rotation on both sides, so I can place my hand on her hip, place my hand on her hip and her shoulder, and I'm going to have you rotate your shoulder backwards as far as you can. Now rotate your spine forward. Okay, we're going to do the same thing on this side. Your shoulder backwards. Okay, rotate forward. Okay, so I actually want you to turn your back. Twist. There we go. Same thing on the other side. Okay, very good. I've checked for rotation. I'm going to have you lean down and pull your left arm down toward your foot, using your back. Kind of sideways like this. There you go. Stand up straight for me. I'm going to have you sort of lean this way.
Okay.
Ready? Just like that. Okay. Up, and on the other side. Okay, very good. I've done lateral flexion on both sides of the spine tested. Now, I've got to also palpate the spine, which I can do that as well. Do you have any tenderness or anything when I press down?
No.
I can check each one of the prominences here. Any tenderness when I press down?
No.
Okay, she's got full sensation there. So the next thing I want to do is I want to assess what we call Romberg. It's a Romberg test. If you could stand and face this way for me. I'm going to actually have you close your eyes. You close your eyes for me. and your hands by your side. And I'm going to see if the patient actually sways or moves significantly or loses her balance during this. I can use the background as a reference point to kind of contrast between her movement. This is, again, a test of vestibular, cerebellar function, balance. This is all part of the neurological examination. If she has a positive Romberg, it could indicate that she does have some vestibular or cerebellar problems. So at the next point, I'm going to ask her to hop in place on one foot, and this is actually going to be a test of her ability to balance as well, and lower leg strength if you're able. If you're able, could you stand on one foot and then bend your knee? There you go. And hop for me. Okay, same thing on the other side. Okay, now with your right leg up and bent, if you could bend down with your left leg. There you go, up again. And then do the same thing on the other side. Okay, good. You can stand normal. Now I'm going to have the patient walk. I want to assess her gait and see how she walks, if she has any difficulty walking or if she has an abnormal gait. I want to watch her. So if you can walk across the room for me, please. Walk towards the door. So I'm going to watch the patient's gait. You can walk back toward me now. Okay, so I've watched her feet while she was doing that, and it seemed appropriate. So we'll come back up here. And that pretty much concludes the physical assessment. So I want to thank you. You did a great job with the assessment. If you can report to the nurse, that'd be great. And
Okay.
I'll be back to see you in a few minutes, and we can discuss the results of your examination.
Okay,
All right.
thank you.
All right. You have a great day.
You too.
All right. And this concludes the physical examination for NP602. It was head-to-toe examination for Unit 2. I'm sorry, this is NP601, Unit 2. And I will thank you for your time. Bye-bye.